Hello, welcome to our final assignment in which we will be discussing this article called Comparison of Safety and Efficacy of Methadone versus Morphine for Treatment of Neonatal Abstinence Syndrome. Here we have that it is published by the Journal of American Medical Association, the Pediatrics Division. It is an original investigation. The first author is Jonathan M. Davis, and here we are, Dulce, Erika, Mayra, and me. First, we have our problem statement that is although opiates are used to treat neonatal abstinence syndrome, the best pharmacologic treatment has not yet been established. And then we have our conceptual framework. That is that first, neonatal abstinence syndrome is a constellation of signs involving autonomic and central nervous system dysfunction that affects more than half of the infants exposed to opiates in utero, although its expression is highly variable. Then we have that opiate misuse during pregnancy is on the rise. As the number of pregnant women exposed to opiates and other psychotropic medication increases, of course, the incidence of neonatal abstinence syndrome increases. Then we have that several different approaches are used to treat the NAS, but there is no universal standard. Opiates have been recommended for the treatment of infants with significant NAS, with neonatal morphine solution or methadone being the most commonly used medication. And then we have that there is significant heterogeneity in treatment approaches, and the safety of and efficacy of many of these drugs has not been adequately established. And some clinicians have recommended treatment with an opioid based on the infant's weight. And then we have our hypothesis, that is the short-term results of treatment based on weight and signs of neonatal abstinence syndrome with methadone are better than those obtained with morphine.
So talking about the type of the design, this was a randomized double-blind intention to treat trial term infants from ADUS newborns units whose mothers received a ibuprofen, methadone, or opioids for pain control during the pregnancy were eligible, and it was a total of 117 infants were randomized for receive the methadone or morphine from February 9 and to March 6th. So that was the type of the design, and the measurement instruments were that the primary endpoint was length of the hospital stay, which her cycles is LOES, and the secondary endpoints were the LOS attributed to NAS as a length of drug treatment. And the sampling technique was the randomization was 1-to-1 according to computer generation randomization sequences by stratified by site and type of maternal opioid use. So it could be like ibuprofen or methadone for the treatment and the opioid use disorder. So opioids prescribed for chronic pain to balance the study arms, and also the mother's treatment with methadone or ibuprofen for an opioid use disorder for an opioid for treatment of chronic pain receiving prenatal care. So this was at least like 1 to 2 obstetric visits in the third trimester. So these were eligible for study inclusion. And the sample, as I already said, was a total of 170 infants that were randomized to receive the methadone or morphine. So this was the sampling technique. And so where were the measured variables? So it was for two different groups. So in first group, we have the mothers, and then second one, the infants. So for the mothers, the variables was the opioid, so the smoking status of the mother, the urine toxicology test result, and the psychiatric diagnosis, the psychiatric medication during the pregnancy. That was for the mothers, and for the infants, or like for babies, or like the gestational age, the breed weight, if the babies were male, the Apgar score, the race or the ethnicity, the head circumference mean, age treatment start, and the urine toxicology test result. That was very important, and the site of the initial care.
Now let's talk about inclusion criteria. Mothers treated with methadone or buprenorphine for an opioid use disorder or an opioid for treatment of chronic pain and receiving prenatal care were eligible for student inclusion. Mothers with a known psychiatric diagnosis could receive additional psychotropic drugs, and mothers were still included if they used illicit drugs during the pregnancy. Exclusion criteria. Mothers were excluded if they consumed more than 3 ounces of alcohol per week during the pregnancy. And all infants that were born at 37 weeks gestation or later. Experimental strategy. Preparation. The commercial methadone contained 50% alcohol as a preservative because alcohol could affect short and longer term outcomes. The U.S. Food and Drug Administration required that the preservative-free methadone solution be prepared using methadone powder. Feeding and scoring. Infants were assessed by nursing staff using standardized feeding and scoring every 4 hours. Treatment protocol. Pharmacological treatment was initiated when the Finnegan scoring was 8 or higher on 2 consecutive occasions or 12 or higher when assessment. Infants received methadone alternating with placebo every 4 hours or morphine every 4 hours. If the infant continued to have a Finnegan score of 8 or higher for 2 consecutive scores or had 1 scores of 12 or higher, the dose was increased to the next level. And endpoints, the primary endpoint was length of hospital stay, and secondary endpoints were that means length of hospital stay related to treatment of neonatal abstinence syndrome, length of treatment with a steroid drug, need for supplemental phenobarbital, weight gain during the hospitalization, and the need for dose escalation of steroid drug. A statistical analysis. A total sample size of 184 was projected to attain 80% power to detect a difference in mean length of hospital stay of 2.3 days. All the statistical tests were two-sided and at a significance level of alpha equal 0.05. Secondary endpoints were not accounted for in the power calculation and were therefore considered to be exploratory. And since all infants whose mothers received opioid pain medications were randomized to only one group, a sensitivity analysis was performed that excluded these infants. Results. Adjusting for treatment, the side and maternal opioid type demonstrate that compared with morphine, methadone was associated with a 14% reduction in mean related to length of hospital stay, corresponding to a difference of 2.3 days. Methadone was also associated with statistical significant reductions in median total length of hospital stay, median length of hospital stays related to neonatal abstinence syndrome, and median length of drug treatment compared with morphine.
The discussion resolves around neonatal abstinence syndrome and strict treatment options with a particular focus on the use of methadone and morphine. The authors note that there is no approved drug treatment for use in infants. Studies have indicated that methadone treatment reduces hospital stays and treatment duration compared to morphine. Methadone has greater activity as support receptor agonist but lower affinity for the receptor compared with morphine. The effects of methadone can vary due to variation in cytochrome P450 enzymes delivered and intestine, which affect its metabolism. Methadone also has a longer half-life and dosing interval due to its increased fat, solubility, protein binding, and volume of distribution. The study refers to comparison in which the choice of opioid may affect the duration of treatment, regardless of opioid exposure during pregnancy, and the factors such as maternal smoking, which is associated with high doses of opioids and longer hospital stays were present. They highlight the importance of developing a safe, commercially available methadone solution designed specifically for newborns as not medication used in the populations or adult dose formulations with neurodevelopmental effects.
And now, finally, for the central learning of this subject, we have that the central learning of the clinical research methodology course has revolved around understanding the fundamental principles, concepts, and methods used in designing, conducting, analyzing, and reporting clinical research results. And we have reviewed various topics such as different types of study designs, development of research protocols, data collection and management, statistical analysis, and critical appraisal of literature, among many others. And the only thing we will seek to improve will be to place a little more emphasis on the bioethical implications of the studies, as well as include discussions in this area to carry out a greater exchange with our peers. And with that being said, that's it. Thank you.